Well, welcome everybody to today's Steinberg Grand Rounds Lecture. I'm Robert Weissman. I'm the Director of the Fellowship in Psychiatry and Law here at the University of Rochester Medical Center, and want to welcome everyone who's come to attend in-house as well as all of our attendees on Zoom today. We'll try to make sure that we speak up and we speak into mics so everyone can hear us. A few housekeeping pieces. Again, welcome on behalf of the Department of Psychiatry and our chairman, Dr. Ben Lee. First off, I want to thank a few people who made this possible. As you know, setting up a grand rounds can be like setting up a wedding. There's a lot of toil beforehand, and sure enough, an hour later, it's over. So a few people I want to thank. Mary Lee Gramlich, I don't know if she's in the audience. If she's not, she's busy doing something. But nothing gets done in our department without Mary Lee Gramlich as it relates to education. And once again, thank you to Mary Lee. Also, Michelle Creamer. Michelle, are you in-house? If you can raise your hand. Michelle Creamer is a paralegal from the Legal Assistance of Western New York, who has made it possible for us to provide continuing legal education credits. For all of you attorneys out there, both in-house as well as on Zoom, you will be able to fill out, click a link and get a code in order to register for continuing legal education credit. As part of that, we also have Ms. Joyce Parker, one of our faculty members in the Steinberg Fellowship in Psychiatry and Law present, who is also allowing us to have continuing legal education by her presence on our panel after Dr. Privitera's lecture. So we will welcome her as well. And before we do formal introductions of Dr. Privitera, I want to introduce Dr. Richard Cecconi, the founding director of the Fellowship in Psychiatry and Law here at the University of Rochester Medical Center. Dr. Cecconi.
Thank you, Dr. Weissman. I'm delighted to add my welcome to the 35th Steinberg Lecture. Lecture was founded in 1988 at the time of Charles Steinberg's 70th birthday. And I also want to take this occasion for special greetings to the Steinberg family, Charles's daughters, Liz and Carol. Charles was an attorney in private practice, but also worked for many years in the public defender's office. Beginning in 1975, he was involved in a variety of educational activities here at the medical center, from grad rounds to lecturing to medical students, conducting seminars for residents, as well as for forensic fellows on topics ranging from involuntary commitment of the mentally ill, psychiatric issues in family law. And in each setting, Mr. Steinberg challenged his students with his intellect and imagination. He brought his rich experiences from the courtroom into the classroom, along with his unfailing good humor. In 1996, he was promoted to clinical professor of psychiatry in the law. On the national level, Mr. Steinberg presented many lectures and addresses at meetings of the American Academy of Psychiatry and the Law, and was a mentor and faculty member at the Apple Forensic Psychiatry course. In October of 1986, he was presented with the Red Apple Award, the highest award that the American Academy of Psychiatry and Law provides for distinguished contributions to non-psychiatrists. With his death in May of 1999, the Department of Psychiatry lost an outstanding teacher, an esteemed colleague, and a loyal friend. We remember him fondly. And with that, I turn the podium back to Dr. Weissman.
Thank you, Dr. Cecconi. This is a special day for all of us. As I introduce Dr. Michael Privitera, many of you have worked, known, and been taught by Dr. Privitera, and for us in our fellowship to bring him in is exceptional, and really looking forward to today's presentation, and that he was willing to come in. I cajoled him with coffee and I think a Danish possibly to do so, which is always my go-to bribe, and it worked on Dr. Privitera, so I'll keep doing it. His lecture today is entitled Organizational Contributions to Burnout and Workplace Violence. This is something that's dear to my heart academically as well as in my clinical work. And there is no better person to be expounding on this topic with the tireless work that Dr. Privitera has done. A little background on Dr. Privitera. Michael Privitera is Professor Emeritus at our University of Rochester Medical Center and member of the faculty of the Institute of Healthcare Improvement and the Workplace Change Collaborative. Dr. Privitera is a recipient of many awards. In 2012, he received the American Academy of Psychiatry and Law, American Psychiatric Association's Manfred Guttmacher Award, given in recognition of making an outstanding contribution to the literature of forensic psychiatry for his book entitled Workplace Violence in Mental Health and General Healthcare Settings. If any of you have been able to review this book, we've had numerous faculty that were involved in this, and Mike spearheaded this, and I highly recommend it in whatever discipline that you're in. Dr. Privitera has given numerous presentations and is the author of many publications. He was on the International Scientific Committee for Violence in the Health Sector between 2014 and 2016 through the OOD consultancy. He was a member of the Federation of State Medical Boards Task Force on Physician Burnout and the NIOSH Office for Total Worker Health and the NIOSH Health Work Design and Wellbeing Program. From 2015 to 2019, Dr. Privitera was chair of the MSS-NY Task Force on Physician Stress and Burnout. He is our guru on these topics and our go-to individual for any questions on these topics. Lastly, but not least, I see Dr. Privitera, and I call him Mike, as a dear friend, a colleague, a mentor since my time here, since my fellowship, and the mark of a true professional in all ways that that could be described and defined. Most importantly, I gauge someone in our profession on whether or not I would send a family member or loved one to them for care and or consultant review. And without question, Dr. Privitera is someone that I would do that with and probably will in the near future. So look forward to that. Dr. Privitera, please.
Well, it's a pleasure to be here, and thank you, Rob and Richard, for wonderful introductions. And it's such an honor to be here on behalf of Mr. Steinberg's memorial lecture. I remember him when I was walking the halls here when he was, so I really enjoyed learning from him and being part of these lectures probably 35 years ago. And so with that, I wanted to also call out a couple people who really influenced me a lot in my what you're going to hear today, and people who have passed. Certainly, everybody knows Dr. George Engel and the biopsychosocial model that started here. What I'd like you to try to do today is to think of biopsychosocial model as applied to staff. We learned about it for patients, but what is the environment, the work environment, the organization, the system doing to staff, especially with stressors that are mounting and increasing? Vaughn Bowie, who was a mentor of mine, he was from the University of Western Sydney, and he was an international expert on organizational contributions to workplace violence, which is a gap in OSHA's typology of violence in the workplace, which is a big error, I think, because as people do reviews about possible contributions, may have been decisions that were made for a system that contributed downstream. But if we don't have that in the typology, it's very hard to put that in an RCA, root cause analysis. So I think that's a disservice, and I hope we at some point correct that. I've already tried to work a little bit with NIOSH about that, which is the National Institute for Occupational Safety and Health. And lastly, Dr. Hal Hendrick, who was a human factors engineer, and he was called the father of macro, which is organizational ergonomics. And that's how to work things in a system more comfortable for the employee, the worker, so they can do their work, and how to change the system in a way that make it more adaptive for the human system interface. So he was called the father of macro ergonomics. And two things he used to say is think bigger, think systems. And the second thing he used to say is good ergonomics is good economics. So with that, we'll go on to talk a little bit about the science of human factors as applied to understanding what's happening with staff. So to give us some language that we can use to describe what's happening and a system of application of improving things. So let's see. I think I missed one. Okay. These are the slides that you need to see. That there's no particular conflicts of interest. I'd like you to also come away with the idea that extraneous cognitive load, that is going to be the toxin we're talking about. Information that could be improved by better design. Too much cognitive load that doesn't need to be there, that if we think about different ways of delivery. So I'll say right now, we have a lot of things and to understand that when a hospital system has so many regulations, they're put upon and they have to do these to keep the lights on. So we know that. But the point of today will be we can keep the lights on and take care of the staff's well-being by application of human factors. So we know we have to deal with regulations. We know we have to do those things. But how can we do it in a way where the control is really how we roll out whatever regulation it is. That's where we have control. That's at the hospital system. But this is very new. At the end, we'll talk a little bit about a paper that's free to download that I just wrote about 3 weeks ago. It came out, and it's a kind of a 12-year capstone of looking at human factor science, pulling from that engineering science, and take information to make it more understandable to a lay person so that you can apply it in a system. I'll put that at the end. So organizational contributions to burnout and workplace violence. What I'm hoping we can show that sometimes terms get in the way. Sometimes if you think about talking about law or psychiatry, for example, somebody that may have been hit, we might call in psychiatry an assault, but in law, we might call it a harassment. So there's a kind of a Tower of Babel issue between fields. The other thing is, like in medicine, first degree burn is less serious than a third degree burn, right? In law, you reverse that order. So we've got a Tower of Babel problem. So what I'm getting to a little bit is, how can we get to mechanisms? What's in common? What's driving things? If we try to take a biopsychosocial approach to what's happening, can we get some improved understanding, especially between fields? So I hope you start to think about questions you'd like to ask. I'm going to really work hard on finishing up so we have time for discussion, okay? So keep those thoughts going. What is workplace violence? So definition, this is from NIOSH, National Institute of Occupational Safety and Health. Physical assault, threatening behavior, verbal abuse in the workplace, includes beatings, shootings, rape, suicide, or attempts. And what's underlying there is also compatible with the Joint Commission Sentinel Event Alert. So what we refer to as disruptive behaviors, psychological traumas, threats to harm, obscene phone calls, intimidation, bullying, incivility, harassment, including being sworn at. So that's what's in common with the Joint Commission. What's burnout? 3 major things: exhaustion, depersonalization, and lack of efficacy. So exhaustion, it's even after a weekend of rest, you come back, you might have a little bit of gas in the tank, but it doesn't last too long. It's from the chronic wear down. The depersonalization, sometimes you start seeing the people you're seeing as things to get done instead of the individual, so depersonalization. You keep your patients or clients at distance so they don't drain you more. It's a survival mechanism. It's because you really are running very low. Lack of efficacy. In the beginning, you think you're not working on as well as you usually would, but as it proceeds, you actually aren't, and you're starting to make mistakes. So it's a pretty serious thing that we have to look at. Regarding aggression, when I first started to get into that, what are we talking about as far as that term of aggression and violence? So got to understand when we look at all the definitions of it, the top part of this metaphor of the iceberg is, we'll call it mega violence, which would be more what law and society's common perceptions of violence. Really severe transgressions, and it comes up with legal consequences: homicide, assault, threats to harm, terrorism. But there's a lot of things under the water level that really can contribute, build up, and are being looked at from point of view society and how it's affecting to us. So incivility, disrespect, causing micro traumas that add up, basically. These do add up. And how much of these together contribute to going upstream to mega violence? What are the conditions? We have to start thinking in three ways, like the person, the stimulus, and the environment. So what we're going to talk today about is more about the environment. So OSHA, workplace violence and typologies: criminal intent, intrusive violence, customer client violence. So 2 could be clinician on patient violence, which is really sad when that happens and certainly illegal. But patient on staff violence is really what really got me involved a lot in studying this. Seen a lot of nurses hurt on inpatient units, sometimes not having the consequences, the accountability, some patients in particular that were repeated offenders. Some, you have to understand that it's their illness, but where is that line? How do we look at the line? Worker on worker violence, you talk about it a lot in the nursing literature about lateral violence, bullying that occurs. Personal relationship violence, that's example is somebody that's a partner that knows where you're going to be and can offend because they know you'll be at work. And so they come into the work, and that's where there may be assault or other things that they might do. So here's what Von Bowie got into. He included organizational contributions to violence to understand how certain upstream decisions, the way organizations are structured and managed, can contribute downstream to this effect. So what is occupational stress? Harmful physical and emotional responses that occur when the requirements of the job don't match the capabilities, resources, or needs of the worker. So that's the definition of occupational stress. I think found this kind of helpful to kind of understand how we start falling apart when too many expectations happened. Vaughn used to talk about the man on the Clappus omnibus, which was the man on the bus that goes on a certain street in England, I guess. It was something that was used in law in England. And the idea being that the average person, what happens to the average person is the point. So here's the point of, we get into different areas that we call stress. Hypostress isn't so good, we're bored. Eustress is the kind of thing that gets us activated so we do better on an exam. But there's a certain point where current expectations go up, fatigue happens, you're into distress, and then hyperstress. So to understand as it continues, if it's not monitored, if there's no feedback system that lets the organization know the overwhelm, then it can continue. And we're a victim of many different bosses as a hospital system. If you ever look at how hospital is affected by regulations and laws and stuff, it's amazing how many factors go in to what keeps the lights on. So we understand what's happening, but how can we organize things at the hospital level so we can take the pressures off and monitor and find a way to apply the work in a way that we can do? So there's distress. What happens from the literature, we find out high occupational stress, there's cognitive changes, physical, emotional, burnout, depression, irritability, incivility starts to happen, risk of error, patient experience goes down, disruptive behavior has been associated with it. And unfortunately, if some people continue to the point of falling apart, death, or suicide. So there's a patient in need. So that's the issue. How can we help before things get too far? Realize this, that actually, because there's too many bosses and they don't, at the national level, do not connect with each other, about what the total load is, it really has to be done at a hospital system. So how do we get smarter about this and catch it? Here's the Hamburg burnout inventory that has aggression as one of the things it picks up on that's other burnout inventories do not. That's what I really liked about this German tool. So what they picked up with increasing as a level of burnout goes up, so does the aggressive reaction to stress. That is missed on other kinds of burnout scales. This is workplace stress and reactions, frustration, anger, satisfaction. Interpersonal aggression goes up, hostility, intention to quit. All not good things. So what do we know in the area, what's in common? The organizational systemic issues in medical error, burnout, workplace finance. Could we get a mechanism, a biological mechanism? What's happening to us? What's happening to our brain? That's where I'm going to try to go with some of this. And you know, from the Institute of Medicine, this started a lot of patient safety movement issues and a lot of what are our quality pay for performance, whole things that came for our payment system and healthcare reform that happened was out of this. But they found that the majority of errors are systemic in cause, not the substandard performance of the individual. It's trickled down to them. They're the last touch with the patient, but the events and the conditions started upstream. Majority of occupational stress is causing burnout or organizational. Our study at MISNY we did in 2016 showed 80% of them were, 20% were clinical. From the point of view of workplace violence, we look at the person, the stimulus, but not enough about systemic environment. What are the conditions that set things up that it could be worse or not? We know that things like when it's hot out, we know violence goes up in a city. We know there's temperature issues that affect the person. We know that, that's pretty clear. Noise starts to cut down our ability to think, so really noisy. In the emergency room, depending on how it's set up physically, the flow of patients can set two people too close to each other, the physical proximity. So can we work with architects as we build things that go in with the human condition of what we have to deal with better? So how do we improve our knowledge and our science as we build things in the healthcare system? So emphasis here is often on the individual. And it's hard to make legal cases sometimes, and we'll talk some more at the end about some of this as the responsibility kind of gets diffused into the organization. It's really hard for accountability issues, but we'll talk about where things are headed because it seems like science is accumulating that's showing we are getting biologically hurt as people that work in this. So things are opening up for the issues of OSHA, personal injury. It seems, I'll show you the literature and then we can have discussion from somebody that really knows what they're doing. So, but I'll show you what I've been seeing and coming up with. So looking at the literature about this vicious cycle of perpetuating forces, there's literature, lots of it, organizational contributions to burnout. There's organizational contributions to workplace violence in the literature. We know that if once you're burned out, you're more likely to be the object of violence from a patient. You're not listening as well, you're tuned out, you're trying to stay, survive your own work. You're not hearing things, and your situational awareness goes down. So you're more at risk to be a victim of violence if you're burned out. And then of course, if lots of workplace violence events happen, that burns you out. So there's a risk of becoming more burned out. The higher the frequency of events of workplace violence, the higher the burnout is, and actually intention to leave nursing, et cetera. Those things all go up with more events. So for anybody interested, the slides will be available. I think they're going to be posted. So there's a lot of the literature that supports this. I'm putting together a model that it's a vicious cycle. So where do we intervene? Let's focus on the organization where we can do something more about it. See what we can do. What are the different components? There's different percentages of contribution, but let's see where we can focus. How can we make things better? Where the things where we can control it. So looking at a lot of the things in the literature about what are some of these organizational contributions to burnout? These are some of them, the characteristics, the demands, lack of resources, how somebody is treated by an employer affects this. Organizational characteristics, complexities, hierarchies, how do you get information to the top? Looking at contributions to workplace violence, the clash of people, complexities of systems, perceptions that the hospital or staff is in it for the money, staff fatigue, demanding work, overtime, not enough people to do the work. So what's in common? So trying to understand what are some of these common factors that maybe if we focus on, because workplace violence, when it's severe, it's low frequency but high impact. When somebody gets hit, a lot of people get concerned and rally, but then that kind of dies down. But that's human nature. That's the organization just trying to carry on. But burnout happens every day. The things that happen in burnout happen every day. So if there's overlap, let's focus on what's overlap, because maybe we can help both is the idea. It's only a educated guess, but this is what we're coming up with. So maybe if we really focus on the organization and decreasing burnout, we can settle the contributors, cut down on the organizational contributions, because those are things we can control if we're leaders. So we're heading into more understanding of what we could do in leadership with the application of human factors. And this is new. So it's being taught now. Actually, it's being picked up at the VA system in St. Louis, University of California, Davis, Christiana Care in Delaware. And they're interested and I'm teaching this next week at the Institute for Healthcare Improvement, which affects 44 organizations that are in this. You heard of the Lorna Breen Act? The Lorna Breen Act was a bipartisan act of Congress that was for providing funds for the mental health of healthcare workers. So from that grant, a HRSA grant was started for the Workplace Change Collaborative. And IHI, which is the Institute for Healthcare Improvement, is the technical center. And I've got an opportunity now to work with them. They're very open to this. So this is one of the people, the groups that hospitals listen to. I call them E.F. Huttons of healthcare. When they speak, people listen. So IHI is one of them. So we're getting in that door. The Joint Commission is, and I'll show you later, is very interested in this work too. And their new CEO just reduced the regulations by 14%. I'll show you that at the end. That they're realizing this is quite, all these regulations and wearing people down, and what's really important. Can we get to what's really important? So we'll be talking more about that. And so this is catching on, it's new, but it's available. If people want to take this very seriously and take it on, if people want to read the paper, I'd be happy to talk to anybody about the details, help coach people along. So anyway, what are the 6 categories of workplace stress that contribute to burnout? This is from organizational studies. Excessive workload, which is physical, but cognitive too, and emotional. So if you work in the ICU and you just lost somebody, there's a toll that takes on you, and you have to kind of have a chance to catch up. You lost somebody in the OR, that has a toll. And we often just keep going. But how do we kind of deal with it? We're humans, no matter what we do. We're all in the human club. So how do we deal with these things as humans? And we have to do better about working that into our workspace. Lack of control. So if we can't influence our work environment, that's another big one. Poor balance between effort and reward. Lack of community. The busier we are, the less community. We don't talk to each other as much. We're all in our EMRs. And lack of fairness, resources, injustice, and value conflict. Moral distress, having to do things we don't quite agree with. That's getting into some of the studies of what's called moral injury. We're debating whether that's really a good term or not, because it's not the same as what happens with a combat vet who has to make the decision to kill somebody and then has to live with that. Is it really the same? I debate that it's not. And because we're still in the giving profession, we're still in that taking care of people, even though we have to. So I think it's a lot like a dissonance, maybe not an injury. So we're kind of getting back to that. So let me give you, this is some of my techno problems. Technology innovation effect. What does technology do as an accelerator? This came from, I don't know if you ever read the book, Thank You for Being Late. Did anybody read that? You did? Okay. It's a great book, especially the first part, where Thomas Friedman, who is a New York Times columnist, interviews people in Silicon Valley and basically projecting where we're headed. You know, what's the moonshot of where technology is. Basically, technology keeps, every time there's something new, the new invention is on the shoulders of the last one. So it's kind of like going up quicker than our human adaptability. So we have to be smarter. We're at that point there currently, and it's outpaced. Our human adaptation is outpaced already, and that's only going to get worse. So we have to be on this. A lot of the things that we have in the hospital system is technology, and we are the recipients through technology of a lot of connectivity, tracking, and accountability has gone way up. Somebody from 2,000 miles away, you can tell if you did something or not because it's checked on your, how are we as humans having to deal with accountability that's gone up that rapidly? And they're all from different bosses. Remember that. So our expectations have really gone up. Tech costs are low, personnel costs are high. It's led to disintermediation, which is taking somebody out of the middle that used to be there to help. Overhead costs shift from the corporation to consumers, patients, clinicians. Spins off shadow work. It's shadow work that's in the background on the remaining employees, and it's basically the unpaid, unseen jobs that fill your day. It's a great book by Craig Lampert, a Harvard sociologist that wrote this book called Shadow Work. And it's all over in our society. If you buy something at Kia, you put it together, and the costs have gone to you and your time to put it together as opposed to the overhead for the corporation. That's one example. So our culture, it normalizes the deviance around us. Everybody's doing it. Everybody's writing notes at night. Everybody's taking stuff home. But that's not normal. We should be finishing it at work, but it's got normalized. And it's a group thing. It dulls our feedback system to say, this is dangerous, it's unsustainable. From the book Shadow Work, for the most part, shadow workers have no one to represent their interests, and they keep new shadow jobs happening. But a great, whose job is it to engineer its reduction should be considered. And something called Wellbeing 2.0 by Tate Shanafelt, I recommend if you're interested in burnout. He talks about how we're evolving to more of a real partnership, administration plus clinicians, that we kind of deal with anything that comes out of the gate together, that we can do this together, that we have to do more partnerships with those doing the work and those doling out resources. And so we have to work together more is the point, because things are accelerating in the last 30 to 40 years. Just a quick review about the impact of clinician burnout. Patient effects, well, this was a study on surgeons. Medical errors go up 200%. Malpractice claims, disruptive behavior, empathy goes down. If you are a burned out doctor, following your treatment regimen goes down. There's reduced patient satisfaction, scores go down. Turnover costs, 40% attributed to the stress. If you are burned out, you go to your physician or APP more often. So if you're self-insured, the costs go up. And short and long-term disability costs. Suicide rate to the person, so in physicians, it's about 400 a year, it's estimated. Major depression, substance abuse, divorce. So all these all this extra work, what's it doing at the home front? All the times you have to do more documentation at home. Heart disease goes up, it's correlated. The higher the burnout, the higher the heart disease. Telomere shortening, which is, it's a sign of hastened aging. They did a study on interns. By the end of the first year, the telomeres got more short. Brain changes, I'll show you that, and a higher risk of being a victim of patient on staff violence. So there's a high correlation between patient satisfaction and career satisfaction, but that's not used enough. That's important, right? If you have a better career satisfaction and it's correlated with patient satisfaction, isn't that important? And a really high correlation. So here's our brain doing the work. If you're an attorney or clinician, this is our brain. It's not a patient's brain. So Our brain on work, basically. What have some of the studies shown? Thinning of the prefrontal cortex. This is our decision maker, our executive function. There was a study in medical students that showed this. After the stress has significantly decreased, that thinning gets better, but your amygdala, which is the area that responds to stress, stayed large. So over time, you're accumulating this kind of micro trauma, micro trauma. Your amygdala is bigger, and are you more reactive to stress? We're also dumbing people down. The more, if it's 6 to 12 weeks, your short-term memory starts going, but after 12 weeks, it's actually your long-term. So now certifications, maintenance of certifications, we're getting people to do this all kinds of the hours of the day they're working, and we're dumbing them down from the stress. So that's the paradox. We have to be smarter about how we are, as humans, trying to do our work and realize we have to do a better job of understanding the impact. So there's a lot of the research about this. I've been able to pair up with Tina Shaw. I don't know if you heard Tina. Tina was, she was a senior advisor for the Surgeon General when they wrote the Surgeon General report on healthcare worker burnout. So she's been really a great support and of human factors for leaders. She's seen this as a really good potential. And I think we're going to go somewhere with it because of the fact person that's been doing a lot of the research in burnout sees this as a way to help us. So I'm very excited by that. So to get the point, a metaphor might be helpful. We think about a gas tank being, we just need to fill up, right? But our gas tank is actually smaller is the point. There's anatomical changes going on. We're not the same. And we have to kind of deal with this. We don't want this to happen. We're chronically burned out, stressed, depressed, anxious, sleep deprived, overworked, underfed. And our society is ramping us up. Technology is ramping us up. And the more that our technology creates all this connection, everybody else's expectations ramp up. So we have to understand this as a organization. Where can we stop? Where do we stop the buck, basically? How can we get on top of this, realize there's a toxin going on here? This is a toxic condition. These are partially reversible, like I said. The intense working conditions over long periods of time without recovery. The big thing that's the toxin, it's uncontrollable stress. We already signed up knowing that we go into medicine, we go into law, there's a certain amount of stress. It's the uncontrollable stress that is the toxin. So how do we relieve the uncontrollability? We need more input. Allow people to start work on improving their work environments. There need to be feedback systems so people can make the needed decisions to improve the work environment, because otherwise it's only the E.F. Huttons that get to the top of the hospital, that downflow of information. And for a lot of power differential reasons, it's not easy to bring up issues. We need to systematize it so that there are feedback systems regularly in business, in our professions, that allow what's the front lines like? What's happening at the front lines? How do you get feedback about it in a way that's expected? And it's not that you're a complainer or you're weak. This is a normal human process. And here's some of the biology of this. So if the stress ceases, some things can reverse. So this is a call for urgent interventions. So to give you another metaphor, kind of a teeter-totter, the limbic system is amped up and the prefrontal cortex is down. So this is what patients are coming to us, and our clients are coming to us for, our prefrontal cortex mostly. And it's the way we think through things. So one thing to keep you from losing your cool too much and flying off the handle is label with words in your mind how you're feeling. I'm really angry, I'm really upset, I'm really stressed. If you put that into words, it helps get your prefrontal cortex back online, but remember, that's temporary. So why is our prefrontal cortex so important? Focusing attention, our self-control, planning, organization, perspective, taking the big picture, flexibility. Cognitive flexibility is going like, okay, I have all these symptoms in front of me. It might be congestive heart failure. I remember that, I got that in medical school. I learned that, I did that in residency. That's your flexible memory of trying to figure out from many things it could be, what is it? As opposed to automatic memory is this, sleep problem, give them a medicine, something automatic. But again, if you're always stressed out, you might miss with that sleep problem. It could be congestive failure, could be depression, could be many things. So your differential comes from your controlled thinking. Deferring gratification, estimating time in your working memory. So how do we look at organizations? There's been terms that come up, toxic work environment. A lot of the work is about bullying. Psychosocial safety climate, I really recommend this. It's from Safe Work. Maureen Dollar did this work on psychosocial safety climate. See the light blue? It's an upstream determinant of many things we worry about in the organization. Keeping psychological safety, how the way it's okay to bring certain things up, routinize this, is a good way to affect all these downstream work-related issues. Organizational health is another term we've come up with. Alignment, employee well-being, organizational justice, processes and workflows are clear opportunities for development, purposeful, meaningful work. So are there mechanisms? Some of our words, like I said in the beginning, are they tying us up a bit? Are there similar, does our brain experience bullying, uncontrolled stress, mandates without resources, microaggressions the same way? In other words, start thinking, are these things in common? What can we find out as mechanisms? Because sometimes our words fail us when we're going between professions. If getting into mechanisms might help us with ways out. So human factors science, what is it? This will be the top view, the high view. So we're gonna, there'll probably be a need for a lot more talk about this, about ideas. But it's a discipline that takes a lot of sciences and interactions with humans and elements of the work system, optimizes worker well-being and system performance. Isn't that the marriage we want? Worker well-being, system performance. That's exactly what we want. Human factors and healthcare. So this is a psychiatrist, I think it's kind of appropriate, right, for this setting. An invisible elephant in the room first. I'm right there in the room, nobody even sees me. That's the human factors effects going on all around us. Then maybe I'm right there in the room and nobody acknowledges me. Some just don't know how to deal with me. Once you see the elephant, but you ignore it. And then what we hope is the elephant, let's take this elephant on. Let's deal with it. I'm glad you're dealing with me, I'm massive. Human factors effects are massive in an organization. So the more we learn the terminology, the better we're going to be. Some reasons for invisibility. Well, people aren't familiar with human factors ergonomics. Authority effect, we do what authorities tell us to do mostly. Financial measures are killing the C-suite. They're always changing. They take up people's thinking, time, pay for performance, quality, what's got to meet all these cost silos. Things are not seeing how one cost relates to the other. And let me talk to you about halo bias. Halo bias, a lot of things get deemed as quality or patient safety. Once that label is there, it's very hard to push back, whether or not it's really good for patient safety. But once people call it patient safety or quality, unfortunately, we don't push back and challenge the science. The trouble is, it's been a tsunami of these things. And there we are again, adding up. So assumption must be good because it's quality or safety. The logic becomes circular. So the proposal here is, what can we do of applying human factors? All these blue hash marks are the typical way we think about human factors, like designing a better system, a better medical device. All these red arrows on that brain is what I've been talking about. See, there's the clinician's brain and all these systemic forces affecting risk for burnout and error. So the newest application is, what can we help leaders understand in science that can help them with this? Why? Because the leader does affect culture, climate, work environment. It's the same thing as the healing environment where patients get served. Communications, allocations of resources, workflow design, rollout of services, implementation of requirements. So the idea is, this is the best place we have for making a difference to taking that off that person's brain in a way that we can affect rollout of various things that we have to do to keep the lights on. So this actually, Dr. Taubman helped me with this slide. He spent, our CEO, helped me with designing this. I said, I have to talk to a lot of CEOs. Could you help me with it? Could I borrow your brain? Yeah, so external requirements, laws, mandates, regulations, keep the lights on, goes to the C-suite, it gets dispensed. Then all those regs go to quality and safety office, finance, compliance, risk management, educational mandatories, billing, medical staff office. So now you have an array of people that go out and march for compliance with those things who don't necessarily know the total mandatory load. The idea of human factors is, well, this descends on those people trying to do the work. Basic knowledge about burnout and cognitive load. How do we collaborate? All those offices, if we collaborate, if there's a feedback system that central office knows the total mandatory load and how we're going to deal with all these mandatories, which we've done here, we started that. How do we coordinate, simplify, harmonize, satisfy, in other words, satisfactory and sufficient to meet the regulation, but nothing more? Make anything more voluntary, but meet the requirement. Sometimes we go to try and get a PhD in everything, which we don't need to do, and we're burning through our brain power and our resource. Provide time to do this. It needs to be provided as a cost of doing business is the other thing. More brain power for better work performance, more satisfaction at work, and the message leadership cares about well-being. So quick study on cognitive ergonomics, basically. Cognition is automatic or controlled. We talked about that. Habit memory versus controlled thought. Differential diagnosis comes through controlled thought, thinking one thing versus another. It's highly uses through a lot of glucose. This is our burning through our resource, our thinking process. It's limited. We don't have an unending supply of controlled thought. So when you think about, you have to do something and think through it. Intrinsic is the basic thing that's unmutable. It's the basic need of what you need to do. Germain, we talked about pulling it out. Extraneous, how can you design it better? How can you clean things up? How do you not make it duplicative? Or, having to figure out, well, when do I do this mandate? Do I not see this patient? How can we figure those things out so you don't burn through that thing unnecessarily? You still accomplish getting it done, but you don't have to think. So extraneous cognitive load burns through and gets into error. Load sheds, goal shielding, you keep out new information. So these are the main things that really burn through a lot of our thinking. Every click matters, it's a decision. Believe it or not, every time you click is a decision. Multitasking, getting back, interruptions count. The time space between information and executing action, working memory, professionalism. Somebody treats you or threatens you. It burns through a lot of brain power to stay on tack and control yourself. Equanimous, when people are bleeding and trying to stay on task. Basically, job demands resources. Demands greater than resources, that's the model of burnout. So how to decrease demands, how to increase resources so that you get rid of the burnout is the idea. Quick thing about environment, the feedback from patient experience and clinicians. Our culture gets in the way for the reasons we said. We need to have systems of feedback to senior leadership so they know where the problems are and can allocate resources. So human factors is one way of getting your technical system and your social system equal. You need joint optimization. This is part of human factors science, how to make an effective organization. It's great reading by Passmore et al., Designing Effective Organization, the socio-technical system perspective. Basically, a lot of things happening nationally in 2022. All these groups came out with taking care of the workforce. This is from the Surgeon General's office, societal, cultural, healthcare system, organizational. It's out of the control of the individual. We as an organization need to do something about it. These are all in the slides and it's in these write-ups, but the idea is too much work, too many regulations. We have to allow more ways to control that. Here's a joint commission coming through with 14% reduction of some of the standards, which is wonderful. This is great. So on a national level, they're getting it. They're forward thinking. So let's avoid the problems that are happening. What could we do here? This is what I'm seeing in the legal literature. Duty to prevent emotional harm at work, science and law implications, corporate responsibility, legal remedies for burnout, workers' comp, OSHA, get a free consultation if you want to sue somebody. Perfect legal storm. There's a lot brewing. So let's get on top of it. Let's avoid what's going on. So I look forward to hearing summary. There's mechanisms, a lot of, see the danger in well-meaning expectation. See a danger in it. It's not get through the halo bias. Total workload, be aware of shadow work. Highly trained cognition is a limited resource. Don't burn through it unnecessarily. Preserve time off, boundaries, restoration. We need policies and culture to be supportive, and we need to get a way to get the requirements done at work. Okay.
Thank you, Dr. Privitera, for an exceptional presentation on an extremely important topic that we're all dealing with. Now I'd like to bring up Ms. Joyce Parker, our faculty member in psychiatry and law and an attorney, to give some discussion on the legal topics related to this presentation. A few minutes for Q&A.
Thank you. I want to give you some general legal information. This is not legal advice. You should see an attorney if you have a particular question or problem. But nevertheless, I want to give the healthcare segment among you some additional information on a basis that you can understand it, hopefully. But I also want to hope to give the legal people in the audience some value added in terms of my comments. There have been various approaches to burnout and workplace violence across the decades in our legal system. Some of them are primarily focused on the individual who's impacted by the burnout or by the violence. There are traditional systems like employee assistance programs, one-on-one, very low intervention, but helpful to the individual who's involved in it. And there's the workers' compensation system that Dr. Privitera mentioned that provides compensation money for people who are impacted on an individual basis by the burnout or by the violence. There's a history in the workers' comp field of evolution in understanding of psychological impact. At first, the workers' comp system was set up to handle industrial accidents where people were physically injured. But then they began to recognize that physical systems can have psychological impacts. And one of my favorite cases is actually coming out of this local area, and it was the old department store downtown, Sibley, Lindsay, and Kerr. And it's a case that went up to New York State's highest court to try to determine whether an individual who suffered a psychological insult could receive compensation under workers' compensation. And it was very controversial whether this would be decided in favor of the worker or not, but was. What happened was the director of store security was not able to cope with many of the demands, particularly during the Christmas season. And he called in his administrative assistant, called a secretary back in those days, to assist him in some of this work. And that's an interesting dynamic in and of itself, where many people whose job title is something like administrative assistant or secretary who are beginning to do the substantive work of the position. In this case, because the employee himself was becoming impaired. She took on more and more of the work. And at one point, he was able to bounce back after the Christmas season. But in 1971, he wasn't making it back to his baseline and was falling deeper into psychological difficulty. One day he called on the intercom and said, "Call the police and tell them to come to my office. She walked into his office shortly after that phone call and found him in a pool of blood having a self-inflicted gunshot wound. That resulted in her suffering a psychological effect that required eventually 2 weeks hospitalization, some recovery, some regression, finally electroshock treatments that were effective for her. But she had quite a disability from that psychological insult. And she filed a workers' comp claim. At first it was granted, but it was appealed by the employer. And on the first appellate level, it was rejected and then appealed to our state's highest court, which decided that it should be granted under the workers' comp system, a recognition of psychological impact. And I think that it is an evolution in that system that we can begin to see in the present system, where we recognize burnout and what it means and how important it is and how it has to be addressed. The single insult that resulted in psychological injury was followed thereafter by a case out of Michigan involving an assembly line worker who was apparently experiencing difficulty in keeping up with the pace of the assembly line and received a lot of barrage of yelling, screaming at him, to the point where he filed a workers' compensation claim for what had happened as a result of multiple stressors. And that was finally accepted by the workers' comp system. So we see a growing sophistication and understanding of the impact of psychological insults on workers. Now, workers' comp is a limited system. It's an individual response where an employee has to file a claim and has to ask for compensation. It's a bad measure of our system that we measure this by the individual workers who go over the edge, so to speak, as a result of these insults. Let's hope that we can evolve a system that works on the system itself and doesn't produce these individual results. But nevertheless, that's what the legal system was coping with. And one of the other areas that the legal system responds is in what's called the tort system, which is a system of legal cases that can be brought by individuals, for the most part, in which they allege that, for example, an employer was negligent, did not put in place proper systems, and that those systems were beyond the reasonable and resulted in their infliction of emotional distress. Then that led to intentional infliction of emotional distress cases, which were cases alleging that the employer's actions were intentional and weren't just sloppy, weren't just careless, weren't just unreasonable. And they have resulted in legal settlements. Again, individual cases brought by employees, but I want to stress that there is a mechanism called class actions. I'm sure you've heard of this, in which attorneys gather together a bunch of plaintiffs who have suffered the same insult, so to speak, and they can have great impact. I think the one that comes to mind historically in this setting are the nurses who joined a class action to address the expected overtime that wasn't supposed to go on the timesheet. And that resulted in significant million-dollar types of settlements and verdicts in the healthcare system and got the attention, I think, of the system in a way that individual cases weren't. The potential for this kind of class action in workplace burnout and violence is there. It might only require that organized plaintiffs' attorneys decide to put together 2 and 2, and the extent of what this injury is across the whole field of workers before we see something like this come about in this field. Another individual response, though, to burnout or violence has been the Americans for Disabilities Act, where a worker will declare that by virtue of this workplace stress, they're suffering something like PTSD and require some modification of their work situation. Might be in terms of of which hours they come in. We're probably seeing it already in people who are dragging their feet about coming back to the physical work site and saying that the stress was too great and they can perform their job. The productivity statistics are amazing about what people have been able to accomplish from not coming into a work site. There are civil rights laws that would result in a claim if an employer's policies were disproportionately impactful on women or minorities, for example. And this is something that shouldn't be overlooked in terms from the supervision standpoint. Something might be disproportionately impactful and not picked up by the system. Think about job categories that are primarily fulfilled by women. And is a system that's put in place more impactful on that category of workers? And does that really result in what's discriminatory? The Equal Employment Opportunity Commission is the federal agency that enforces this law, and some of their solutions are more systemic than the individual lawsuit, but there is a potential for those as well. And again, the potential for the type of class action lawsuit that would be quite impactful. One of the things I wanted to point out that New York State is called an employment at will state. And this means that you can be fired anytime for any reason, unless you have an employment contract that provides otherwise, or unless that reason is discriminatory or violative of some other particular provision of law. This means that if you are in a position where you have to say, can't do the work here, need accommodation, and you're not successful in getting that accommodation legally or the like, you may wind up being discharged. So you're at risk of your employment in New York State in a way that you might not be in some other states. The regulatory reform, I think, is really impressive that you pointed out, but I wanted to lift up that some of it is COVID-driven and has specifically been cited for the reason, in particular, for the OSHA regulatory change and for the Joint Commission change. So I hope it is a trend. I hope we can continue with those kinds of systemic approaches, but I think we have to be careful about whether it was primarily an artifact of our pandemic. One of the things I also wanted to ask you to do is to consider volunteering for a panel that's being put together for OSHA for the development of a healthcare system specific standard that would address these things. And when we look at statistics like 5 times as much violence in the healthcare setting as other industries, I think the need is quite clear. And I would suggest to you, it's like they used to say to us in the old-fashioned VISTA program, if you're not part of the solution, you may be contributing to the problem. So there is an opportunity to volunteer for this panel that's developing the standard, and I would really urge people to consider doing something like that. And for attorneys, I have to lift up to you a particular ethical rule that deals with becoming aware of all the legal challenges that you might see come in your office. Be prepared either by your own study to address them or refer them to other attorneys. And that is the standard on competence, which is Rule 1.1, 22 NYCRR, this is attorney talk, apologize, 1200.0. So those are some of the legal systems responses to workplace violence and burnout. And I hope that you will, again, consider becoming involved in the solution.
Thank you, Ms. Parker, for your extremely interesting and pertinent comments here from the legal side. Obviously, I'm mindful of the time. I want to be able to take one question, maybe. You had your hand up in the back. Let's get a mic for you.
So my name is Emmerich. I'm a current intern here. And as we're going through this, you talk about some of the systemic and institutional contributors to burnout. And I think we go through that list, and at least personally, I can kind of identify with all of those. And I think on a daily basis, I experience the stressors that were listed that contribute to burnout. And I think I knew coming into this, I wouldn't have agency over my time. But one of the things I learned in this lecture is that I don't have agency over my burnout. which is, I said, like, one of the things I learned from this lecture is I knew I didn't have agency over my time, but I don't have agency over my burnout. And so what is an actionable solution when we know that our institutions and systems are not gonna change in a time frame that is reasonable?
I mean, that's the $1 million question right now, it really is. So I see it as kind of like the aircraft carrier that has to turn slowly and the speedboat. So what do we do in the speedboat thing is we're waiting for the aircraft carrier to change. A lot of it is the individual work, but there's circle of influence where I know, I don't know if Jessica happens to be, Jessica Shand, Dr. Shand is charge of the wellness committee, and then work, and Dr. Tom Osinski is he's surgical attending now in urology. They are working together as a system here to try to see what can be done within the circle of influence, what can be done in your department. And for residents, there was a residency committee that started. So reach out to them about what's going on here that can be done now, you know, call system issues, just how you can help in the meantime while the big system is trying to change. So what are the speedboat things we can do now? But the more leaders that within each circle of influence, what's local, what's in your department, the more you learn about these kinds of things that you can apply in your system. Like one of the people I'm working with from NASA is one of the people in this collaborative that I'm part of for human factors. She was going to different healthcare units and said, I can't believe that they're all made up differently. How are people supposed to find things? They spend all that brain power trying to, you know, just some of the things we do in healthcare. So what can you do in your circle of influence to start applying human factors to say, this will be better, we can make this better. We don't have to do it this way.
Thank you, and I know people have to go, but if maybe one more question and then we'll have to close it down. Please, let me get you a mic.
Hi, I'll be really fast. This is a country really built a lot on productivity and achievement, and I think about that in contrast to, you know, say France recently who's had those protests about the retirement age going from like 62 to 64, for example. Are there lessons we can learn that apply to healthcare from other countries, other cultures that have less of a focus on the high productivity, high achievement realm?
I think there's a lot to learn from other cultures that was there anything you want to say from the legal point of view, or?
I just think it's interesting that our Supreme Court has complained about having the law of other nations cited to them. It's not controlling or precedential, but it's very illustrative. And I think we have to not be intimidated and continue to look at other countries' experience. This world is becoming very small. And I think we have unique opportunities to put that before the decision makers and let them deal with it and dismiss it if they want to. But I think we have to keep raising it.
The one thing in the slides that I had about the legal implications, one of them about OSHA, the full write-up on that refers to information that's done in Europe and some of the cultural things that we've applied for OSHA there that we haven't in the States yet. So there are lessons to start to draw from, and we need to make those parallels more, but it's a slow process again. But it's, you know, talked about, and that's the research we can do to make it better.
Thanks everyone for attending both, please. Excellent, and thanks both of you, Dr. Privitera and Ms. Joyce Parker, for your presentations. Remember that the slides will be available, and for continuing legal education credit, there will be a link with a code for all the attorneys that wish to get that. Thanks again for attending, and thanks all the folks from Multimedia.